All right, hi everybody. I know I'm the presenter in between us and lunch, so we're going to go through managing different types of CV complications. My name is Madi. I am the cardiology resource nurse at Houston Methodist West. And my background is mostly in cardiology. It's what I'm passionate about. So we're going to go through some complications. So the complications we're going to review is post-operative or post-procedure bleeding, cardiac tamponade, vasoplegia, vascular complications, and then cardiac arrest and how it differs between post-cardiac surgery patients and other patient populations. So our learner objectives is going to be to demonstrate an understanding of different post-operative complications in our CV population, how to identify and treat post-operative bleeding, how to identify and treat cardiac tamponade, how to identify and treat vasoplegia, vascular complications and treatment, and then the proper resuscitation of a CV patient in cardiac arrest. So post-procedure bleeding. So with any type of bleeding, we want to do an assessment first. So where is this bleeding come from? Did the patient come back from cath lab, and so we're having bleeding at the insertion or puncture site? Are we having excessive chest tube output in our post-CAP patient or post-CV surgery patient? And so when we're looking at our chest tube output, we're going to look at greater than 300 mLs in an hour or greater than 200 mLs per hour for 2 consecutive hours. Is the patient hypotensive? Is there reason they're hypotensive is because they're bleeding? Do we have a low hemoglobin? Are they having decreased cardiac output, kind of like what Becky talked about, because we're in a hypovolemic state? Or are we having decreased urine output because we don't have enough circulating volume, we don't have enough cardiac output, and so now our kidneys are taking a hit? We also want to determine the cause, a medical versus a surgical cause, or did the patient maybe have a long pump run? And then we want to get some labs. So we want to look at our CBC, PT, PTT, and fibrinogen, again, to kind of get a picture of what we're looking at when they talked about blood conservation. What is the cause of our bleed? Do we need to replace our clotting factors, or do we need to replace red blood cells? So when we're looking at the cause, medical versus surgical, so if it's a medical, like if the patients come back from cath lab and we're bleeding at the groin site, we want to hold pressure to stop the bleed. If we're losing blood, most of the time we want to replace it with blood, so administering packed red blood cells. If we can administer protamine to help reverse the effects of heparin, we can give FFP for coagulopathy and deficient clotting factors, platelets, and cryo. If it's a surgical bleed, the patient may need to return back to the OR to have the bleed controlled. So groin management post-PCI. So if bleeding occurs from the catheter site, we want to make sure that we're applying firm manual pressure first. We don't want to use a sandbag as a first option when we have a bleed from a heart cath, so we want to make sure that we're applying firm pressure to the site. And we want to hold about 2 inches above the puncture site. You can see in the picture the person's hand is not directly on the puncture, but slightly above. You want to hold pressure for a minimum of 15 minutes. Obviously, you want to make sure that you're achieving a new hemostasis time, and you do want to let the physician know that the patient bled. We're going to talk about a retroperitoneal bleed, but just to make sure that they know that the patient did have some bleeding after, we may need to extend our bed rest or see, they may want to get some labs and make sure we don't have deficient clotting factors or a prolonged bleed time. So retroperitoneal bleed, it's an unusual but a potentially serious complication after a cardiac cath or a vascular procedure where we've accessed the femorals. So the retroperitoneal space lies directly posterior to the peritoneal cavity, and it's associated with a higher morbidity and mortality. So some risk factors for patients that could have a retroperitoneal bleed, if they have a low platelet count, female patients are at higher risk, different sheath removal protocols, if the patient was excessively anticoagulated, or if they have a prolonged or elevated PTT. And so to diagnose a retroperitoneal bleed, you can get a contrast-enhanced CT, and that will help to guide where the bleed is, how big it is, and what interventions we need to put in place to stop the bleed. So if you look at the picture on the right, you can see in the red circle the bleed and how it's kind of pushing up. and the little kidney's kind of squeezed up there. So signs and symptoms, they can be vague and nonspecific. So a lot of these patients are having to lay flat for 6 hours. They've been on the cath lab table. And so when they come down complaining of back pain, we don't always think that they're having a retroperitoneal bleed because we're making them lay flat. And anytime you tell the patient they can't move, everything hurts. So we want to kind of, dig a little deeper into what the back pain is. Ask them if it's different than before, and then you want to look at their vital signs. Are they hypotensive? Again, sometimes patients come out, they've had anesthesia, and so they may be hypotensive in general, but those are the things to still let the cardiologist know if you are seeing, because it could lead to a bleed. If they're having abdominal pain, inguinal tenderness, symptoms of hypovolemia, the flank ecchymosis or the gray Turner sign, which is where they have bruising on their back. If you're seeing that, that's a very, very late sign of retroperitoneal bleed, and we need to move quickly. Some treatments for a retroperitoneal bleed, we can give IV fluid resuscitation for the hypovolemia. If it's excessive blood loss, we may need to give blood, and then if we cannot get control of the bleed, then they may need to have a surgical repair. So on to cardiac tamponade. So cardiac tamponade is compression of the heart that impairs filling and then therefore decreases cardiac output. So there's a couple different causes. So obviously it's fluid that builds up in the pericardial sac. In patients that have had cardiac surgery, this is where our chest tube maintenance comes in. We want to make sure that our chest tubes are patent and draining. So if you notice that there is a sudden decrease in your chest tube output, we need to let the surgeon or the nurse or advanced practice provider know, because the fluid can build up around the heart. And then it can be a common complication of heart cath or cardiac surgery. So your assessment, you could see an elevated CVP, increased SVR, decreased cardiac output. They can be tachycardic and hypotensive. Again, that sudden decline in chest tube output, and they can be tachypneic or dyspneic. So to diagnose cardiac tamponade, echo is going to be the best diagnostic test for tamponade. And then the treatment for tamponade is going to depend on the patient's symptoms. Some patients come in and they have mild symptoms of tamponade, or they come in and then they're in shock from their cardiac tamponade. So we can do a pericardiocentesis where they're going in percutaneously to drain the fluid, or they may need to go to the OR for a pericardial window. With the window, they're probably going to come out with chest tubes. So again, making sure that your chest tubes are patent and that fluid and blood is able to flow. And then if it's a post-CAB patient, they may need to return to the OR for exploration. Vasoplegia, I know Becky touched on this, but we'll just kind of go through some of these things. So vasoplegia is the persistent low systemic vascular resistance with a normal cardiac index. So we want to identify and treat this promptly, because obviously we don't want these patients sitting in a low cardiac output state, and so treating quickly and efficiently is the best way to take care of these patients. So we're going to start with fluids and vasopressors. So adequately treat them with fluids, kind of fill that tank back up, but then we also, if that isn't working, we may need to increase further. Vasoplegia has an increased morbidity and mortality, and it has a multifactorial pathophysiology, and so sometimes that's why treating it can be difficult, because there's different reasons that the patients can become vasoplegic. So it's from endothelial dysfunction due to oxidative injury, elevated levels of endothelin, vasopressin deficiency, or overproduction of nitric oxide. And then again, if the patients are on pump for a long time, they can come out very vasoplegic. So to treat vasoplegia, again, we're going to start with IV fluids and making sure our cardiac function is optimized before progressing on with our care. So if we've given our fluids and patient is still not responsive, we can go ahead and start vasopressors. Becky mentioned norepinephrine is our first line agent, and so we like it because it increases the MAP and cardiac index without causing the patient to be tachycardic. Because if we cause the patient to be tachycardic, we have decreased filling times, and our cardiac output won't have any effect on it. Our norepinephrine's not working, we can move on to vasopressin. It can help raise MAP in cases where the endogenous vasopressin is deficient, causing the shock, and it helps restore some vascular tone. So if we've put the patient on norepinephrine, the patient's on vasopressin, we're working our butts off and their map is still not improving, we get to go to methylene blue. Like Becky said, it makes your urine turn a pretty color, and it looks kind of like a melted Jolly Rancher in a bag. So it helps suppress the vasodilatory effects of cytokines, and again, it's contraindicated in patients with SSRI. So usually we will exhaust our doses of methylene blue before we move on to any other agents. So our two other agents, one is angiotensin II. It's responsible for vasoconstrictive effects of the renin-angiotensin-aldosterone system. So it increases aldosterone release, vasopressin release, and sympathetic response. It's a treatment response, again, when we've on rocket fuel of vasopressors or a methylene blue has not worked. It's not given very often. It can be a very expensive medication, so it's usually kind of a last-ditch effort. And then again, the B12 derivative, it helps suppress nitric oxide activity. It will turn your urine a pretty color. Sometimes their skin will even kind of get a red tint to it. And you do have to be careful how close together you give methylene blue and B12 because it can have some effects. But the angiotensin II and the B12 are kind of your last ditch efforts to help the patient overcome their vasoplegia. So moving on to some different vascular complications. So acute limb ischemia. So it's a rapid decrease in lower limb blood flow, usually with an occlusion of the peripheral artery or a bypass graft. The prognosis is poor unless it's rapidly identified. And a lot of times we have patients that come in and they have chronic peripheral vascular disease, and so maybe they've developed some collaterals and things like that. But the difference with acute is that there's no collateral circulation. So the blood flow is acutely cut off and the patient comes in with a cold leg. And so because they don't have collaterals, we have to treat it promptly and quickly to prevent the patient from losing that limb. And because it's an acute, it causes sudden severe symptoms. So some of the symptoms we see, as we're all familiar with, is the 5 Ps. So we have pain, pallor, the pulse is either absent or diminished, paresthesia, and paralysis. So diagnosing it, we want to look at the extremity. Our assessment is always one of our most important tools in nursing, and so making sure we're looking at that, like, what does it look like? What's the temperature of it? Do we have a pulse? When did the patient notice a change in condition? And just kind of start investigating what is going on with that patient, and then we can get a CT of the leg. To treat acute limb ischemia, we can do a couple different things. We can start them on a systemic heparin infusion to prevent a second clot from forming on that patient. Sometimes we need to go in surgically and remove the clot or bypass the artery. If the patient has had a cold leg for a long time, there may be no salvaging it, and the patient may need to have an amputation. Endovascular treatment, they can do now a catheter-directed thrombolysis to try and prevent the patient from having to go to the OR. Maybe they're not a good surgical candidate. They have other things going on, so they can do that. And then sometimes they can place a stent. But with acute limb ischemia, early identification, early treatment, we talked a lot about mechanical circulatory support. A lot of those devices have big cannulas, and so we're sticking it into an artery, and so making sure we're checking our limbs and our pulses, making sure that if we are occluding something in the leg or with the balloon, the arm, that we're rapidly identifying it and seeing what we need to do to prevent that patient from having a loss of a limb. So compartment syndrome is one that we're all pretty familiar with. This is just what you wanted to see too before you went to lunch. It's increased intramuscular compartment pressure due to increased capillary permeability, and it oftentimes occurs when we've gone in to revascularize an extremity. So the increase in the pressure leads to circulatory and neuromuscular dysfunction. If it's not treated promptly, it can cause irreversible nerve and muscle necrosis. So when we have patients that come back from any time of revascularizing their extremity, we want to watch for swelling around the leg. Increased swelling can mean that we're maybe developing some compartment syndrome and hopefully avoiding the picture. So some causes of compartment syndrome is reperfusion, vascular injury, burns because of the inflammatory response, crust injuries, and then tight bandages and wraps. Sometimes we have patients that have wounds or things or lymphedema, and so we're dressing those wounds, and if they become too tight or they start to swell, that can cause compartment syndrome. So treatment, if there's a tight bandage or wrap, loosen it or remove it. Again, for severe cases, fasciotomies, which is in the picture, to kind of allow that muscle and tissue to expand and not cut off circulation, and then again, in worst cases, is an amputation. Complications of compartment syndrome, they can develop rhabdo, nerve damage, numbness and weakness from the compression and the swelling inside the limb, and then infection if we're having to do a surgical intervention. So aortic aneurysms. So an aneurysm is when a part of the artery wall has weakened and it's abnormally ballooning out. So we can either get a thoracic aortic aneurysm or an abdominal aortic aneurysm. And on the picture on the right, you can see what a normal aorta looks like, and then the ballooning of the thoracic and the abdominal. So risk factors for an aortic aneurysm is tobacco use, high blood pressure, atherosclerosis, and the family history. So symptoms, like they were talking about earlier, a lot of the thoracic aneurysms may not have any symptoms. Sometimes, depending on the size of it, they may get difficulty swallowing or hoarseness just because of the location. But most of the time, our symptoms are going to be seen with abdominal aneurysms. So they're going to come in with abdominal pain. If you're doing your assessment, you may feel like a pulsatile mass in their abdomen, and nausea and vomiting. Treatment of the aneurysm, it really depends on the location and the size of the aneurysm. Some of these, if they're smaller, we can medically manage them. Their blood pressure control is going to be huge. Patient education is huge with these because we want them to prevent it from rupturing and getting larger. And then if the aneurysm does need repaired, we can do it surgically or endovascularly. So treatment, when the aneurysm is greater than 5.5 centimeters is usually when they will do surgery, or if it's rapidly expanding, or obviously if the aneurysm has ruptured, we're going to take the patient to the OR. We can do an open repair or an endovascular repair. The TVAR is the endovascular procedure for a thoracic aortic aneurysm, and then EVAR is for the abdominal. And then we want to have strict blood pressure control on these patients, so making sure that we know when these patients roll out from the OR or we're receiving them from the ICU, we know what our blood pressure parameters are because we need strict control. So an open repair is the most common. The actual aneurysm is removed and then they sew a graft in so the patient comes out with a new part of their aorta. And it's a large incision in the abdomen or the chest if it's a thoracic. It's a very invasive procedure. These patients come out and they're usually pretty sick. Endovascular repair is either an EVAR or a TVAR. It's obviously less invasive, and it's similar to an approach with a heart cath where they access the femoral artery. So they're able to go up the femoral artery, and then you can see in the picture on the bottom right where they're actually able to put in a new graft in the aorta and basically create a new aortic wall for these patients to prevent the aneurysm from rupturing. So complications of open repairs, obviously they can hemorrhage, and then abdominal compartment syndrome for our abdominal aortic aneurysm patients. It can be seen when the aneurysm itself has actually ruptured. You want to monitor for increasing abdominal girth, if their abdomen becomes distended, tender, rigid, things like that. We often will measure intra-abdominal pressures in our open abdominal aortic aneurysm patients, and then they can become hypotensive and tachycardic. We want to monitor for renal failure. Again, we're dealing with the aorta, and so if these patients go into a low cardiac output state, our poor kidneys are always the ones that take a hit, and so we want to monitor for their urine output. And then again, they're at risk for infection because we have a very large incision. So some complications of endovascular repairs, limb ischemia because we're accessing that femoral artery, and so making sure we're doing our pulse checks, all of the same things we would do for our heart cath patients. We want to monitor for renal insufficiency. So with our EVAR grafts, as you can see in the picture, the renal arteries are just above where we put the graft in. And so if the graft goes too high, it'll block off the renal arteries and we'll see a decrease in our renal perfusion and then decrease in our urine output. They can develop DVTs and PEs. They can have bleeding, hematoma from the femoral site. Again, bowel ischemia, because if the graft migrates up too high, we can block off blood flow to the gut. Spinal cord ischemia, this can be seen with the thoracic endovascular repairs because of the location of where they're placing the graft. The patients can have spinal cord injuries, and so sometimes the patients will come out with lumbar drains to manage cerebral spinal pressures. Endoleaks is probably one of the more common complications post-endovascular procedures. So that's where blood leaks around the graft back into the aneurysm sac. So sometimes it's not a lot of blood loss around the graft, and so it can just be monitored. But if it's a significant amount, again, we have a weakened artery wall, and so if we're putting blood into that, which is what we're trying to prevent, they're at risk for rupturing the aneurysm. And then again, infection. So then now onto aortic dissection. So this is a condition in which there is a tear in the lining of the aorta, and then that tear causes there to be a false lumen. And so that false lumen can rupture. So we have a type A, which affects the ascending aorta and the arch, and then type B, which affects the descending aorta. So risk factors for aortic dissection, the chronic hypertension, atherosclerosis, patients that have a connective tissue disorder, if they have a history of an aortic aneurysm, cocaine use, and then a family history. So clinical manifestations, severe chest pain, that's tearing, ripping, or shearing. A lot of times we will see sometimes patients that will come in through the ER and they're complaining of this really sharp chest pain sensation, and we'll see them go to CT first. A lot of times it's to rule out that they're having an aortic dissection because this is a surgical emergency, usually, and the patients will go to the OR. They can have pain in their back, abdomen, or legs, shortness of breath, sweating. They can also have a blood pressure that's different between two arms. So for some of those in the ER, if you have a patient and you're checking blood pressure on both arms, you have a dissection, there'll usually be a pretty significant difference between the two. And they can also develop cardiac tamponade. So treatment, if it's a type A dissection, it usually require immediate surgical repair. They can do it open or endovascular, and then the goal is to prevent rupture or tamponade. And then type B, depending on the severity and the symptoms of the patient, it can be surgically repaired, or they may medically manage it. Again, blood pressure control with these patients is vital. And so you can see the endovascular stent here. And so again, it's similar to the aneurysm where we're just trying to block off that false lumen to prevent it from rupturing. So resuscitation after cardiac surgery. So we are going to look at our post-sternotomy patients a little bit different than when other patient populations have a cardiac arrest, because we're dealing with a fresh sternotomy patient. So the Society of Thoracic Surgery actually has some recommendations to modify the AHA ACLS algorithm, but in the ICU setting, not on the general floor. And so the STS recommends that a patient can have an emergency resternotomy to be a standard part of the resuscitation protocol up to 10 days post-surgery. And again, this is in the ICU setting, not for patients on a general floor. And we do not want to use an automated external compression device on our post-cardiac surgical patients. And so a lot of the ICUs and things are moving towards doing like open chest drills, having open chest carts, open chest teams, things like that, because they're showing that doing these resternotomies in these patients is helping to improve their outcomes. So post-sternotomy arrest. So VFib is the cause of cardiac arrest in about 25 to 50% of these patients. So the STS recommends that we deliver 3 sequential shocks for VFib before we start chest compressions. STS says that we can delay our chest compressions for up to a minute in order to administer these 3 shocks. They would prefer to use a manual defibrillator over an AED because that way we can give the shocks faster and then prevent the delay in the resternotomy. And then, as we know with anything, we want to defib patients as quickly as possible because their survival after a post-hospital arrest for VFib is better when we can defibrillate them. For patients in asystole, a lot of our patients will come out with epicardial pacer wires, so we want to be able to connect them to the box and try and overdrive pace these patients at the maximum atrial and ventricular output voltages. Again, they say we can delay chest compressions up for 1 minute to attempt pacing. For both of these cases, if we cannot get treatment to these patients with either pacing or defibrillation within a minute, we want to go ahead and start CPR. We don't want to, wait for 1.5 minutes, 2 minutes before we start our chest compressions. And then medications, epinephrine and vasopressin, we would just, want to use some caution before we start slamming epis in these patients because we have fresh grafts and we just want to make sure we're not then going to cause this significant rebound hypertension or bleeding once we get ROSC back. So this is the algorithm put out by the STS, wanting to assess our rhythm, and then dependent on if we have these tools readily available, if we can quickly defibrillate them, pace them, we want to do that and then start our basic life support, our medications, and then prepare for an emergency resternotomy if we're in the ICU setting. And I talked really fast too, and that's all that I have for you guys.